All right. So, um, I just made everything into one slideshow, but I'm just gonna do the first few medications all in one video, just because they all kind of deal and relate with pain. And I think that's a little bit easier. So yeah, I'll just go ahead and get started with the first one off the bat. Acetaminophen. Um, you know, very well known as Tylenol. It's used as a pain reliever in mild to moderate pain. Its mechanism is still a little bit unknown. It's kind of in the mix, but what is kind of known is that it works to block, weekly has some blocking of prostaglandin formation. And prostaglandins are lipid-based molecules like fats and stuff that are based from fats that are used to induce swelling, redness, pain. It says mainly in the CNS, but it does do this in the PNS as well, is what helps with that pain transduction out in the periphery. And also there's a interesting fact where it has some interactions with the serotonergic system, basically working to raise the pain threshold, so the amount of pain that would be required for you to feel it or be like consciously aware of it. It's metabolized in the liver for the most part. And this is going to come up later in the contraindications. And then there's some weak research out there that maybe, not a ton of evidence that it might be better for fever as compared to another drug on this list that we'll go over next, ibuprofen, as opposed to pain, but it is still good for both and it should be used for both. Now, when we talk about the indications and the dosing, like we said, it can be used for severe pain. So it's usually thought of as like mild to moderate when you take it, like orally. So in the, sorry, excuse me, in the mild pain condition, for the adults, it's usually, a lot of times acetaminophen will come in 325 milligram tablets. So, 325 could be like your low dose, and then 1 gram or 1,000 milligrams is considered your max. And then peds, once again, when we're taking it for mild pain or fever, the same thing goes. The max is 1,000. It'll be the adult dose, and it's weight based at the peds dose, so it'll be 15 milligrams per kilogram. So you got another weight before you give it. And then for more intense pain, you can do an IV push of acetaminophen. So this is still weight based, and you'd only give it one time, but the dosing would be 15 milligrams per kilogram, and then you could give a max of 1,000 milligrams, and that's just because, if we push it IV, it doesn't have to go through first pass metabolism, and so those effects can be a bit more targeted and fast acting as compared to if we took it orally. So now we need to go over some contraindications. The first one is obviously allergy. That'll be for basically every medication we have on here. Liver disease, or liver failure, because it can be, the liver is what we need to metabolize this drug. And so if we have an issue there, we could easily lead to toxicity or some sort of potential overdose. Altered mental status, at least for the oral route, right? Because we need them to be able to follow commands to take it. And then another thing on here, it's just a good idea to ask somebody how much they've taken, how long ago they took it, just because this is such a common household drug that people will oftentimes self-administer it when they're dealing with something like a headache or a fever or something. And, if that gets worse, you want to know how much they've already taken so you don't accidentally overdose them. And then I just put a little picture of acetaminophen right here. So you can see it's kind of has like a similar structure to serotonin. It's got that catechol group on the left, which may give it some of those properties. The next one we're going to go through is ibuprofen. So this one's kind of similar to acetaminophen. It is, it's an NSAID, so that stands for non-steroidal anti-inflammatory agent. It's used for mild, moderate pain. We don't really use it for more severe pain. AEMTs are not going to give this via like a IV push or anything. We're always going to give it orally. And like I said, there's a little bit of research that maybe this is better for pain compared to acetaminophen. And one of the reasons I wanted to say that is it's blocking these enzymes called COX-1 and COX-2. So COX-1 and COX-2, the COX stands for cyclooxygenase. And these are basically enzymes that are required to make prostaglandins, which I said in the last slide was used for pain signaling. It also helps with regulating blood flow, vasoconstriction versus dilation. We get some of that swelling, that redness. So it feels, ibuprofen has a bit more direct inhibition of those enzymes, which might make it better for pain as an analgesic compared to acetaminophen. And some of that might be that we just know the mechanism a little better. So like I said, indications and dosing, mild, moderate pain. If you want like a number for that, that's usually anywhere from 2 to maybe 6-ish on the pain scale. And you can, also kind of see by like the mechanism of injury or what they might be going through, what their pain scale might be if they can't really give you a number. The adult dose is usually, anywhere from 400 to 800 milligrams. Some people can take as low as 200 milligrams because the tablet size, at least household, is usually about 200, which is very common. And then the peds dose, once again, just like acetaminophen, it's weight-based. It'll be 10 milligrams per kilogram at a max of 800. And the route is always oral. Now, contraindications. Now, one of the things I wanted to say, just like acetaminophen, this is a super common household drug, so you need to ask patients if they've already had it to prevent overdosing them. Obviously, there's going to be issues with allergies or hypersensitivity. Ibuprofen goes through, a vast amount of elimination through the kidneys. So renal disease, transplant renal failure, anything like that is a contraindication, hard contraindication. We can't give ibuprofen because they can't eliminate it that well. Pregnancy is kind of similar to that because the baby or the fetus is not able to metabolize this drug and eliminate it the same way. So ibuprofens, you generally don't want to give it to pregnant patients. And you also, you don't want to give it in the case of GI bleeds because prostaglandins can be important for regulating blood flow. So if they have issues with prostaglandin formation, part of it regulates renal flow, blood flow to the kidneys. So, it can also affect like GI bleeds and that sort of thing. So we don't want to give it to patients who have histories or like recent GI bleeds or bleeding, things like that, because we can make that worse by blocking the prostaglandin formation. And then there's the structure of ibuprofen. So it's kind of similar to acetaminophen in a way. The next one that we're going to go over is Toradol, which is very similar to ibuprofen. It's an NSAID, so a non-steroidal anti-inflammatory agent, just like ibuprofen. It basically has the same mechanism. It blocks COX-1 and COX-2, so we are limiting prostaglandins, right? And those are needed for inflammation and swelling and pain transduction. But the difference with Toradol is kind of that it is much more potent, is much more powerful as an analgesic. So it is usually, if it's prescribed to you, it's prescribed over a much shorter period of time. But that also means that when we're using it, we're not using Toradol for, if you just stubbed your toe or something. We're using Toradol if you've broken your arm. We're using this for severe mechanisms of injury that are bringing you intense, very intense pain, 7, 8 higher on the pain scale. So this is kind of where its use, even though it's still an NSAID, is a little bit different than ibuprofens. As far as the indications in dosing go, like we said, we're doing it for moderate and severe pain. The adult dose can be given IV or can be given IV, IO, or IM. So I have that in the route, but the dosing changes depending on which way you're giving it. So we can give it 15 milligrams if we're giving it IV or an IO push. And then we're going to go 30 milligrams if it's IM. IM is just a little bit slower, and it also is not getting directly into the bloodstream as well. So that's why we use that higher dose. Peds has the same dose regardless of all routes, and the max will be 30 milligrams. So the max IM dose for adults, and it's weight based. So we're going to give 0.5 milligrams per kilogram to peds. And then contraindications are all basically the exact same as ibuprofen. This goes through very similar metabolism routes compared to ibuprofen. Has very similar mechanism. So, like we said, the allergy, renal disease or failure, GI bleeds, the prostaglandins, and then pregnancy because of the fetus. Next thing I want to go through is lidocaine. So lidocaine is used to, it's used for pain, like all these other medications are, but it's a little different because lidocaine is, getting texted about a trip. Lidocaine is used as like a local anesthetic usually. So a lot of times in the field, we will use lidocaine as a way to compliance with like IO access. So if someone's awake and you got to drill them and you can't get a vein, you got to do IO, it's going to hurt like shit. So pushing lidocaine there can locally numb that area without having maybe some systemic effects, and you can increase their compliance with that, and they it might not hurt as bad. So obviously analgesic, numbing agent. Another thing is it's an antiarrhythmic. So this is often used in cardiac arrest. I don't think that's authorized for the AEMT scope, but I thought I'd go over it anyways. It basically does the same thing either way, is that it is blocking sodium channels on nerves, which is preventing, it prevents that action potential from generating, which means, we're not sending signals across those nerves, and we're not going to be feeling, if I block the nerve endings in my hand where I've injected lidocaine, then when I touch it, I just won't feel anything because the nerves don't transduce any of that signal. And so as an antiarrhythmic, it does the same thing because it's still blocking those sodium channels. So we're trying to fix, VFib or VTAC so that, if we shock them, we can get everything back in sync. Can maybe improve the efficacy of a AED or something like that. So in terms of indications and dosing, it's indicated just by pain. Usually we're thinking about it in this case for IO access when we need to drill, and they just can't usually deal with the feeling of that. For adults, the dose will be 20 to 40 milligrams. So I had here, it's usually supplied in 100 milligrams in 5 milliliters. So that would be 20 milligrams per 1 milliliter. So for adults, if we're giving 20 to 40 milligrams, we would give 1 to 2 milliliters. Peds is weight-based. It'll be 0.5 milligrams per kilogram. And yeah, like I said, we're usually pushing this IO. The only real contraindications that I was able to find were, allergy, hypersensitivity. The one thing that I wanted to note in terms of, using lidocaine is that it is possible to induce a seizure if you if you give them too much, because when lidocaine crosses the blood-brain barrier, it can basically block excitatory, it's blocking those sodium channels, but it can block these excitatory these inhibitory neurotransmitters from being sent, stuff like glycine and other inhibitory neurotransmitters, and lead to, what we would call excitotoxicity, which would basically cause you to have unregulated excitatory signaling via something like glutamate, and that could lead to you having a seizure. So it's possible that if you measure this up wrong, or maybe someone's already had lidocaine, or if they're just very sensitive to it in some way, that you could end up causing them to have a seizure. So it's just important to note that. Next thing, which I think is the the last drug that I'm gonna go through in this video is nitrous oxide. So, everyone knows this, laughing gas, stuff you get at the dentist's office. You might get it, it's usually not given, it's a pretty mild anesthetic. So, if you were in the hospital or, getting a treatment or something like that, you wouldn't just be given nitrous oxide. It's not usually the only, anesthetic that is used, but in the EMS field, it's, pretty handy. It can just generally alleviate a patient's sense of pain or how much pain they're in. Usually how it does this is in the CNS. It will cause the release of endogenous opioids, which are generally feelings of euphoria or happiness. To some extent, there's a bit of sedation there. And it also just has general CNS depression effects. So it's inhibiting some of the excitatory signals, which helps, contribute to some of that laid back. Sometimes, it's, anti-anxiety. It's like relaxing, anxiolytic. In terms of the dosing, we always refer to the dosing of N2O, of nitrous oxide in terms of a ratio with oxygen. So we always give it as a mix of nitrous oxide as a gas and pure oxygen as a gas, because it can, with the CNS depression, it can slow your respiratory drive and prevent you from oxygenating as well as you should. So in order to prevent any sort of, adverse hypoxia, we always give it to you in a mix of oxygen gas. And usually these ranges are between 50-50 and as high as 70-30 for more severe. I think the minimum has to be at least 25% oxygen, but for EMS, I think they cut it at 70-30 just to be safe. And then there are some contraindications. Altered mental is usually not a great, you usually don't want to give something like this to where someone's altered mental, because they the patient will hold the mask themselves. So you need them to be able to follow directions. And that kind of helps self-titrate, self-teeter the amount of nitrous oxide that they get, because as they get it, maybe they get a little woozy and kind of pull it away from themselves. And that helps us just keep them comfortable while we need to do what we need to do. First trimester pregnancy, I think in general pregnancy, you usually don't want to give them, but in particular in the first trimester, I think it's just very, very difficult with the underdeveloped organs for the fetus to be able to metabolize any of the nitrous oxide or excrete it. Severe respiratory compromise, this already slows the respiratory drive, so we don't want to worsen that. And then pneumothorax or other gas-filled cavities, I just put pneumo because that's kind of the most relevant to our fields. But nitrous oxide basically has a blood gas partition coefficient that is different compared to oxygen or nitrogen, and thus it's able to fill these cavities significantly faster. So we could be putting excess air in cavities like a pneumothorax and worsening it with nitrous oxide, even if they are in pain. So it's usually not a good idea to do that. And then B12 deficiency, I think nitrous oxide can interfere with vitamin B12 uptake. That's a relative, contraindication. I just put it on the off chance that, somebody maybe asked for it and has a history of a vitamin B12 deficiency or some sort of condition or something, then it's, this might be a good time to know it. But yeah, those were the main medications that were used for pain management. And I will be making some other videos in a sec for the other drugs. So thank you very much for listening.